it, this isn't like a full hour, so we should get there before class. So don't panic that we might not finish before class time, okay? Because there are 4 practice MARs, but the concept is really the same in terms of checking the meds and drawing up your insulins. All of that is the same for each MAR. The things that are going to be different for each of the 4 different scenarios is, do you need to mix insulins? Do you need to give like a short acting and a long acting so you can't mix them? Do you need to give a nutritional dose, or do you need to give a correctional dose, which is what we consider like our sliding scale insulin? But the process that takes the longest in the actual art of scrubbing your hubs and doing your 3 checks and drawing up your insulin is the same for every single one of the 4 different scenarios. And you have the practice MARs, the comp MARs are the same types of scenarios, just different dosages. Okay, so if you practice with these practice MARs, when you get to your comp MARs, you'll do fine. Just don't expect it to be the exact same doses that you're giving, but the actual situations are identical, okay? So if you spend some time, you should be good. And some things we've already talked about related to insulin, right? You took your test on Tuesday, some of which was tested there. So when you come to do your insulin comps, you need to make sure that you know about all of your different types of insulin that you were just tested on, the onset, the peak, and the duration of them as well. And you'll need to verbalize that to your instructor during your comp, all right? So we also need to understand those definitions that I gave you and posted on Blackboard, because we need to understand that if we're giving a nutritional dose, we're giving a correctional dose, do they need to have eaten? Do they need to have breakfast at the bedside? Does it not matter if they've eaten? And remember, our correctional doses really don't matter if they eat or not. That's just to correct the blood glucose that they currently have. A nutritional dose is based upon food. So if you're giving some sort of nutritional dose, which often is a standard dose, like 5 units with every meal to cover the set amount of carbohydrates they're about to consume in that meal, then we certainly need to make sure that they eat. If they're getting Lispro insulin, that really fast, rapid acting, that's the one where I said you probably better have their food at the bedside, right? Because it's going to start working within 5 to 15 minutes. Your regular insulin, you have more of a 30-minute window for that onset to really occur. So you can give it, and then as long as lunch shows up within that 30 minutes or breakfast, whatever meal it is, that's okay. And remember, we have our intermediate and our long-acting insulins. Our long-acting insulins we cannot mix. So that's something we need to know for our comp. If one of our comp situations is to give a rapid-acting and a long-acting, or a short-acting and a long-acting, we can't mix those in the same syringe. So ultimately, you might have 2 syringes that you need to administer to your patient. Okay? Is that going okay?
It just gave me a battery.
Oh,
low
geez.
battery.
So just know what you can mix, what you can't mix, right? What you're going to have to mix for your comp is going to be your short acting and your intermediate acting, which is that whole clear to cloudy business, right? And we're going to go through that in the MAR today. So you need to make sure as well that you get the correct insulin vial. You can see in here how many different vials there are, how many different concentrations there are. So there is one 500 unit concentration, so you got to really make sure. In practice, it would be like bright red, yellow, like really obvious. But of course, we didn't make that obvious for you here in the lab. So you really need to look at these vials when you're going to give to make sure that you don't have the one that says U500. I'm going to pass this around. So this says 500 units per milliliter on it. It does have these little like bars on the side, but like I said, in practice it would be like bright red or yellow. It's not very common. It might even be stored in pharmacy. I've never in practice seen a concentration that high. So know that it's really rare, but we might have some patients who require really large doses of insulin at home. So instead of giving themselves like 100 units of insulin, we just give them a higher concentration of insulin so they can give themselves less units, okay? There's also those 3 different syringes. So in class, I think I only had 2 of them. And so know that you'll want to pick the one that's best for you, 0.3, 0.5, or 1 full milliliter. And why that happens is that the increments on here for the smaller ones are easier to see. On the 100-unit insulin syringe, to give 2 units of insulin is really, really challenging because the unit measurement is really, really tiny up there. And so it's challenging to do that. Certainly I could do it if this was the only resource that I had available, but if it wasn't, I would want to use something like this 0.3, which the unit markers on here, you can see are much larger in between those lines. So it's a little bit easier to draw up just 2 units. Remember, if we're giving insulin, we're always using an insulin syringe because the unit of measurement on there is a unit. Sure, this holds 0.3 milliliters, one holds 0.5 milliliters, one holds 1 milliliter of volume, but this is actually dosed per unit, which is what insulin is dosed on. So you're always going to use the one that says insulin. And there's no way to change the needle. So we're going to pierce the vial with the same needle that we're going to administer to our patients. These needles are super, super tiny and they're super, super sharp. Your patients barely are going to feel these little tiny injections, okay? What route is this med going to be given? Sub-Q. So where are the most common areas that we're going to administer it?
Back of the arm.
Back of the arm is good for us as healthcare providers because they can't use that site. Where else?
Lower stomach.
Yeah, lower stomach. They might also give it in the thigh. And remember, they're often using those resources, so we'll typically go to the back of the arm there. And it's such a small dose that even going in the back of the arm for someone who doesn't have a lot of sub-Q tissue will be fine. As long as you can pinch up a little bit there, you got enough sub-Q tissue to give it. And why do we give insulin sub-Q instead of oral?
Because it irritates the stomach?
Yeah, the stomach denatures it, we call it. So if we gave it orally, it would never get to the bloodstream. It would never get to the pancreas. It would never get to the cells. It wouldn't do its job appropriately. So it has to be given sub-Q. There's really no other way to go about it. And we give this to our type 1 diabetic patients and also to our type 2, but definitely to our type 1s because they need to have the insulin. Okay. All right, so let's look at our sheet here. And let's look at our first MAR, which is Charles Edwards. So I did attach some like step-by-step sheets for you to follow. So you should be able to use this to follow along in practice after this demo. The only thing that I just found out this morning is wrong on there is that the insulins are not in the MDU like the rest of your meds have been. They're going to be right in the med cart at the bedside. So you won't need to go to the MDU and pick them up and come back. Everything will be right in this cart, and so you'll do your 3 checks right at that cart. So just take note of that when you're doing that on the skill sheet. I had forgotten about that piece, but Em reminded me this morning. So Charles Edwards, remember all of your stuff here, these MARs look identical to what you're used to practicing with, no different. Remember, you're gonna prepare your medication on that first check. So when you pull the insulin out of the drawer, you're going to check it against your MAR. You're going to draw it up at that point, label it appropriately, and then do your 3 full checks. So you're kind of going to do 2 checks at this same station outside of the room, and then you're going to go into your patient's room, scan your patient, and do your 3rd check in the room, as you've done with all of your medication administrations. That part should be getting a little easier, right? We've done MedPass, we've done IVs now. We're kind of getting more into that routine. So your comp card will tell you like what time to give the insulins at. You know, these practice MARs aren't going to tell you exactly what time your comp card is going to say to give 730s or 1600s or whatever. So make sure you practice and kind of know the situation for the different times that are on here. So for Charles Edwards, it looks like he has 38 units of NPH insulin due at 7:30 and 14 units of regular insulin due at 7:30. So he's got a short-acting insulin and an intermediate-acting insulin. What's the first thing we need to know about our patient before we give insulin?
Their blood glucose.
Their blood glucose levels. So you need to ask your instructor, tell them, I would check the blood glucose levels. They'll tell you what the blood glucose is, okay? So if we wanted to give NPH and regular insulin to our patient, what are we gonna do with those insulins? Separate syringes, same syringe, what are we gonna do? same syringe. So this is where we're gonna mix our short acting and our intermediate acting insulin. So this is that whole clear to cloudy. And here our intermediate acting is cloudy, but know that clear to cloudy is kind of a term we use. There are becoming some intermediate acting insulins that are not cloudy. So we need to understand really that you draw up the short acting and then the intermediate acting insulin. But in the lab here we have cloudy insulins. We also have these pre-mixed insulins that say 70-30 on them. That means it's like 70% one insulin, 30% another insulin. These are pre-mixed, we call them. So we don't mix these with anything either. These are often given a couple times a day to patients so that they work really quick and they have the long-acting effect. So when you mix clear and cloudy insulins, this is virtually what you're doing, is this pre-mixed already. So I'm going to set those to the side. So we're done with those. Here's another one. There's just so many in here, it takes me like so long to get through them. So we need a regular insulin, correct? Mm-hmm. And we need an NPH insulin. So here's our NPH. You can see that it's a little bit cloudy. These do settle in the lab, and so really you need to gently mix these vials. Now, if you do it before you even start anything, you might have to do it again right before you're gonna get ready to draw it up. In practice, you won't see them settle as much as in the lab, but it's good to see that because it's a good reminder that we need to gently kind of reconstitute that medication, okay?
Just NPH or all of them?
Just NPH, yep. Insulin's also a couple guidelines of insulins that we, I think, previously talked about in class. They're really only good for 28 days, so they should be marked and labeled. If you're opening a new vial, it should be marked with the day you open it and the day it needs to be discarded. Often in the hospital, we fly through these vials way quicker than 28 days, but it depends on where you work. Some patients keep these refrigerated when they're not using them, but ideally they're at room temperature when we go to give them. The absorption is a little bit better at room temperature, but you might see some patients talk about how they keep them refrigerated. It helps them. They might get 3 vials at a time, and one patient might take them considerable amount of time to use 1 vial of insulin. All right, so we have our 2 insulins. We pulled them out of our cart here. We need to, of course, pull up our Mars. So you guys know where these are. Same place everything else has been. These ones, of course, are under insulin. What do we have first, Charles Edwards? Of course, we go to view, edit, document. So I'm just doing my first check here. So I have my 2 insulin. So how many units do I need to give altogether? What? I heard someone say it. 52. So that means I can't use the 30 unit and I can't use the 50 unit. My only option is to use my 100 unit syringe because I have to give 52 units. So anything between 50 and 100, you have to go to your 100 unit syringe, which is the largest syringe. So I first, of course, want to check. Now your skills checklist talks about a second nurse being present. And when you're drawing up 2 insulins and mixing them in the same syringe, it's really challenging to do 3 checks of each insulin and 3 checks of it. The nurse should be present during the entire process of drawing this up, because how are they going to know what really ended up in this syringe based on so many units of this and so many units of this if they didn't actually see you draw up both? All insulin in most all facilities is a 2-nurse check before you administer it. Usually what happens is 1 nurse prepares the whole thing. Then the second nurse comes up, verifies what the blood glucose level was, looks at the order, looks at the syringe, looks at the vial, and signs off that it's the correct dose. But when you're giving 2 in the same, they really need to be present for all 3 checks so that they can see exactly what went into that syringe. Okay? So I'm first gonna, look at my insulins. I got NPH, I wanna give 38 units, okay? I got my regular, I wanna give 14 units. Now I'm gonna draw up and prepare these medications. I'm gonna, of course, cleanse the top of these. These are multi-use vials, so they're getting used a bunch of times. So they really need to be cleansed appropriately before we get started. You can use the same alcohol